My name is Timothy Donahue. I am the Chief of Surgical Oncology and a Professor of Surgery at the David Geffen School of Medicine at UCLA and UCLA Health. And so the question is are patients eligible to have vein resection and reconstruction? If so, how is this determined, and is there a survival benefit or R0 resection rate a difference? It's a really good question. Patients are eligible to have vein resections, oftentimes. These patients usually have borderline resectable or locally advanced tumors, and for the most part should be treated up front with systemic therapy, perhaps radiation therapy, to really select the candidates who would benefit from this more complex operation than just a straightforward Whipple. The things we look at for venous resection mainly are how much of the vein is involved and whether or not there is a good vein inferior to where the tumor is located that can be used for reconstruction. We need to be able to have a good inflow of vein to reconstruct, whether that be in an end-to-end fashion to the portal vein, or with a vein graft, including a jugular vein or a saphenous vein. But the thing that I really look at is does the tumor extend too far inferiorly into the root of the mesentery to get towards where the superior mesenteric vein branches or its tributaries, which make it what is called unreconstructable because there isn't a good inflow vessel that can be used for good mesenteric drainage. Is there a survival benefit to vascular resection or R0 resection rate difference? I think to take the second part of the question first, I do think that there, in cases where there is a vascular venous resection done, probably at a little bit higher risk to having a microscopic margin positive resection, R1 versus R0. And that mostly occurs at the uncinate margin, which is near the superior mesenteric artery, because oftentimes these tumors are head tumors or they're uncinate tumors that involve not only the vein but tissue back there that's very difficult to get out or remove because of the superior mesenteric artery. So a little higher R1 resection rate when a venous resection is done. And then is there a survival benefit? Yes, in well-controlled studies from the surgical literature, multivariate analyses controlling for all other factors associated with the tumor, like lymph node positivity, grade of tumor, et cetera, size of tumor, et cetera. The things that I've seen precipitate out with regards to the vein resection are that can affect survival or prognosis are if the tumor invades through the full wall, so it doesn't just involve the adventitia, but actually invades all the way through the intima of the vein. That's usually a concerning and negative prognostic sign. And also if the margin of the vein is positive, and the margins that we look at on the vein are both the superior margin and the inferior margin. And if those margins still have tumor in them, then that's thought to be another negative prognostic sign or feature, and honestly is considered to be an R1 resection. All in all, patients are eligible for venous resection. Most of these patients have received preoperative chemotherapy, sometimes radiation therapy. We look for whether or not the vein is what we consider to be reconstructable. And the main thing we're looking at there is the inflow vein from the mesentery to make sure that there's a good diameter vein that can be used to reconnect it to the portal vein, whether it be end to end or with a graft. Vein cases with vein resections are associated with a little bit higher R1 resection rate. But just having the vein resection done alone, especially if it's done by a surgeon who does many of them in a place that does a lot of them, doesn't necessarily have all that strong of a negative prognostic implication or impact. And the survival is driven by other features of the tumor and the treatment, like nodal positivity or receipt of neoadjuvant or adjuvant therapy. But the two that do potentially matter are if the tumor invades all the way through the vein wall, and or if the superior and inferior margins of that vein are positive. Say, most tertiary quaternary centers across the country, high volume pancreatic centers, are routinely doing vein resections now. I think I do probably at least one a week or one every other week. This is something that we just started doing, I'd say maybe 10 years ago as a field. Certainly went through a learning curve on the technical aspects of doing it, and also the optimal treatment sequence, and that these patients should receive upfront therapy to select for those patients who would benefit from undergoing what is a more complex resection of their tumor than a straightforward Whipple operation.